Hi, ladies and gentlemen. This is Bev Tenenholtz. I'm a cancer genetic counselor who's here to talk about hereditary breast cancer. I wanted to tell you a story about a patient that I saw recently, because behind all the science and everything that we're going to go over, there are people. People who are scared because cancer is such a frightening experience. People who are scared because they've probably seen and taking care of people in their families who had cancer. I saw a patient yesterday whose mother and sister had had breast cancer and were known to have a BRCA mutation. This patient, let's call her Mary, came with her mother, let's call her Janet, and her mother came with her to the appointment. Through the entire conversation, Mary was very quiet, and her mother was quite chatty and very excited at the thought that Mary was going to be having this testing. Towards the end of our time, I asked Janet to leave so that I could talk to Mary directly. And when she left, I said to Mary that I was interested in hearing what she thought and had to say about the testing process and what it would mean for her life. And basically, the first thing she said was that I'm scared. So your patients are going to bring a lot with them when they come to see you. They're going to bring their experience with cancer in their family. They're going to bring their own feelings about what's going on, and they're going to bring a lot of family baggage. So, hopefully, over the course of your master's degree, this will help you to help your patients make that journey. But let's talk about breast cancer. How common, in fact, is breast cancer? Just recently, breast cancer passed lung cancer as the most common cancer in women. In fact, 1 in 8 women will receive a diagnosis of breast cancer during their lifetime. Some statistics from the Center for Surveillance Epidemiology and End Results, better known as CEER, a division of the NIH or a program of the NIH, indicated that the estimated number of new cases of breast cancer in 2017 was 252,000. And the percentage of all new cancer cases that represented was about 15%. Unfortunately, even though there have been improvements, the number of people who pass away from breast cancer is still over 40,000, which represents almost 7% of all current cancer deaths, again, in the current year. The number of women currently living with breast cancer by 2017 estimates is over 3 million. And one of the amazing things about this number is that approximately 10% of these women will have hereditary breast cancer. There are some risk factors for breast cancer. The number one is aging. Overall, all cancers are related to aging. The longer, I like to say, the longer we're on Earth, the more our bodies have been exposed to, the longer that we can develop different diseases, comorbidities, other things can happen that increase the risk. But other areas include race. We know that certain ethnic populations carry increased risk. Gender, where you're talking about breast cancer, obviously the heaviest burden is carried by women. Food, what kind of foods you eat, although things have been back and forth about how much of an effect diet actually has on cancer risk. Exercising, lifestyle choices like smoking, and of course, family history. These are all things that contribute to your breast cancer risk. The American Cancer Society in 2017, sorry for the error, came out with these numbers. At the age of 20, the average woman has a far less than 1% chance to develop breast cancer. 10 years later, that risk still has not reached 1%. This is not, in general, a disease of young women. By the age of 40, we've hit 1.4%, and by the age of 60, that risk is about 4% and starts to level off, in part for the fact that there may be fewer people in the population in those age categories. While most cancer is sporadic, whether we're talking about breast cancer or other cancers, some cancers actually goes under the name familial cancer. What familial cancer essentially means is that there may be multiple individuals in a family that have cancer, the same cancer, different cancers, so that it seems like a lot in the family, but there may not be a clear pattern, and there's not a clear or proven hereditary cause indicated for that cancer. And at the bottom, you'll see that about 10% of cancer is truly considered to be hereditary, that can be linked back to a change in a specific gene. So what are the red flags then for hereditary cancer? Well, one is cancer at an earlier age. We looked at the numbers. How common is cancer, breast cancer in your 30s and 40s? Not much at all. So that when a woman presents with breast cancer in her 30s, risk factors rather, for breast cancer in men can include early age of menarche, when you got your first period, age of first live birth. So the earlier a woman gets her period and the later you have a baby, the more you've had a steady stream of high levels of estrogen and progesterone almost uninterrupted in your system. Whether or not a woman breastfeeds seems to be a factor that contributes to this, as well as late menopause. The later that you stop having your period and those estrogen and progesterone resources in the ovaries turn off, is definitely a factor. If you've had breast biopsies, this is something that oncologists tend to use to determine future breast cancer risks. Because if there have been abnormal or atypical enough looking cells in the breast, then that causes enough concern to think about breast cancer in the future. Like I said, men can have breast cancer, although that's pretty rare. And in most men that have been surveyed who have had breast cancer, at least 20% of them have a first-degree relative who is a woman who has female breast cancer. So another indication that a lot of male breast cancer is related to a hereditary syndrome. I mentioned ethnic background. We know that there are certain groups in which the likelihood of getting certain cancers is higher, either for related to location, related to diet, related to cultural aspects. In the Ashkenazi Jewish population, for example, this is the Eastern European Jewish population, we see that the likelihood of a mutation specific to the BRCA1 and 2 genes is significantly higher than the general population. In fact, in the Ashkenazi population, there's a 2.5% chance, or 1 in 40, that a woman with or without a family history may have a BRCA mutation. And these are called founder mutations, when you find a mutation that's more specific to that population. We also see founder mutations in the Icelandic population, which makes sense when you consider that Iceland is an island. In the Finnish population, Dutch, Irish, Scotch, again, England is an island, and Norwegian populations have all been identified as sources of very specific mutations. Now, how do founder mutations come to bear? And I apologize for how this slide got kind of cramped. Imagine that there's a population and there's a genetic change that originally occurs. And for whatever reason, be it another disease that wipes out part of the population, be it a limited space so that there's not a lot of people who can fit in that space, be it something like World War I and World War II, where, for example, the Ashkenazi population lived in limited space and therefore had limited availability to find a mate. Those genetic changes become reinforced because now they're a bigger part of a smaller population. And so generations later, we see them at higher levels, even when things change about the mating patterns, because we've had more people, a higher percentage of people with that founder mutation. And below you can see there's 3 very well-known founder mutations, 2 in BRCA1 in the Ashkenazi population, and 1 in BRCA2, as well as well-known founders in the other populations. What are additional risk factors? Well, they can be the pathology of the breast cancer. Breast cancer, as you probably have learned, comes in many flavors, invasive ductal, invasive lobular, DCIS or non-invasive ductal cancer. What we see in women with BRCA1 mutations is they tend to have this picture, this pathological picture, which can include medullary, which is a certain change you see, basal type, or what's come to be called triple negative marker phenotype, which means that when you look for estrogen receptors on the cells, and progesterone receptors, that's the ER-PR part, those are lacking, meaning that the cells of those breast cells or those breast cancer cells do not have a way for estrogen and progesterone to be used as a growth factor. HER2 negative refers to a medication called Herceptin. Herceptin is used as a treatment for certain breast cancers, but in the face of HER2 negative breast cancer, meaning that there aren't any receptors for the breast cells to use that, Herceptin is not necessarily a useful tool. Interestingly, in women with BRCA2 mutations, we see any and all pathologies very close to what we see in the general population. So there's something different about BRCA1 that leads to these unique kind of phenotypes. But family history is probably the one component that really stands out to people who come for genetic counseling or for people in clinic so that somebody can identify that they may be at increased risk. Now, even without considering genetic testing, having a family history in and of itself increases the risk. And it may be because of an unknown genetic change. It may be multiple genetic changes shared within that family, each of which contribute some degree of risk. But in a woman, again, that has no family history of breast cancer, 1 in 8 women will still get breast cancer over a lifetime, statistically, to about age 80. If there is at least 1 first-degree relative who had breast cancer, that risk doubles. And if there's more than 1, that triples or gets even higher. So even without genetic testing, it's always important to remember there's a risk here. There's a risk here anyway for women and men that have a strong family history. There are different ways that in clinical counseling and in clinic we use to help identify people who meet the guidelines or the people that we want to come in to see for genetic testing. One group that has presented guidelines that are pretty closely followed is called the National Comprehensive Cancer Network. And another is the United States Prevention Task Force. Both of these groups looked at large numbers of women and their family history and genetic test results to determine which are the highest risk populations. And basically, what the NCCN says that starting with a patient who has had breast cancer themselves, factors such as we talked about, early onset, specific to being under the age of 45 and having breast cancer, for example. Specific pathology types, such as triple negative breast cancer. Specific ethnic types, like being of Ashkenazi Jewish ancestry, or having these patterns of two or more individuals in multiple generations on the same side of the family with genes related to the BRCA, with cancers related to the BRCA genes, are reason to investigate that family further. When we talk about cancers related to the BRCA genes, that can include breast, ovarian. In some families, we see an increased risk for pancreatic cancer. And in some families, we can see an increased risk of aggressive and metastatic prostate cancers. In patients without a personal family history, if those individuals, women or men, have a relative, first or second degree, who meets those guidelines, then they meet the guidelines for testing as well. And this is extremely important because in any given family, the best individual to test is somebody that's had a cancer personally. But those people are not always available. They may have passed away, they may live in another country, or they may say, and this is not unusual, that they've already dealt with their cancer and they are not interested in pursuing genetic testing anymore. But that risk may still lie with other family members. And this approach to guidelines allows for those family members to consider genetic testing themselves. Under the USPTF guidelines, they're a little bit broader. They look at the age of 50. They look at bilateral breast cancer as an independent risk, also look at male breast cancer, what that family history looks like, and ethnicity. So there are some differences and there are some similarities. One of the importance is that different clinical groups may choose different guidelines to use. Most groups that I'm familiar with use the NCCN guidelines. Also, insurance companies, because ultimately, if you have a family who wants to pursue genetic testing, we're going to be asking their insurer to cover the cost of that testing. And insurers start with one of these guidelines for the most part, and then may make changes relative to what they perceive, how they perceive they want to cover their subscribers. There are also statistical models that are incredibly helpful. Maybe there's a family history that looks like it's high risk, but maybe not. Maybe there's a family where there are multiple individuals with breast cancer, but they're of older ages, and you may not be sure whether or not people meet those guidelines or may be close. Statistical measures then become really helpful in trying to determine whether or not or what the risk would be for a BRCA mutation. There is a statistical program, and I encourage you all to go onto the website and pull it up so that you can see it and maybe play with it. You do need a subscription, but it doesn't have any cost involved with it, called BRCA Pro. It uses Bayesian statistics. It'll draw out your pedigree, multiple generations, and then it will also calculate the likelihood of a BRCA mutation in various family members. There's also a smaller, less unwieldy statistical model called the UPenn2 out of the Vassar Center at the University of Pennsylvania that takes 10 questions where they basically pulled the 10 most important factors associated with increased risk for breast cancer and put them into an algorithm. And that also will tell you what the family risk is and what that individual's risk is to have a BRCA mutation. One of the ways that I found that this is truly helpful is that some people who consider their family history to be very strong by their own measures, but not necessarily strong or meeting guidelines by ours, may be surprised that these models will give them a relatively low risk to have a BRCA mutation. And that can be one of the ways that you can be encouraging to people so that they have a clearer understanding of what that risk truly is. So let's talk about the BRCA genes. The BRCA genes are the showpiece of hereditary cancer studies. They were identified in the 1990s by a group led by Mary Claire King at the University of Washington. There are two of them, BRCA1, which sits on chromosome 17, and BRCA2, which sits on chromosome 13. And these are currently the highest risk genes associated with breast cancer known. So when a woman comes in and says, I'm concerned about genes associated with breast cancer, I'm interested in having testing for the BRCA genes, this is what she's referring to. That BRCA term has become common parlance. So these are tumor suppressor genes, which kind of act like brakes. And I don't know if you've seen this before, but what these genes do and what these proteins do is regulate cell growth so that they control apoptosis, make sure that cells do not grow out of control. When there's a mutation, a germline mutation, and it's like losing a pair of brakes, but you still have, if you have a four-wheel drive car, you still have another pair of brakes and maybe you can stop. But the somatic mutation that happens will drive that car then into the wall, which is cancer. So this is two-hit theory about how cancer happens, but it really goes back to the BRCA genes dictating the production of BRCA proteins that then control apoptosis or allow cell growth to become unregulated, which in the simplest molecular sense is how cancer starts. Again, the BRCA genes were named pretty straightforwardly, BR for breast and CA for cancer. These are called cancer predisposition genes, and that's also a very important aspect of this to make clear with the folks that you're talking to. Not everyone who has a BRCA mutation will get a cancer. Is there an increased risk? Yes, there is. Is everybody going to get a cancer? No, there's not. There's also a point that is kind of a picky point for me, to be honest. And a lot of people will say, my sister has the gene, or my cousin doesn't have the gene. I like to point out that we all have the gene. Every man and every woman has 2 copies of BRCA1 and 2 copies of BRCA2. It's kind of what version of the gene we get that helps dictate what that cancer risk might be, whether or not there's a harmful change or mutation in the gene, or whether the gene is intact and functioning normally. The primary cancers are breast and ovarian cancer, specific to these genes. So when we talk about the BRCA genes, increased risk for breast cancer, male and female, depending on the gene, and increased risk for ovarian cancer, obviously in females. These are dominant genes, and they generally produce those cancers at younger than expected ages. But that is averaging out. So the youngest woman that I personally have had the opportunity to work with who had a BRCA1 mutation and got breast cancer was 19. And the oldest woman was 81. So there's a huge range at what the age might be for a person to experience breast cancer from a BRCA mutation. But the average age is in the mid-40s, as opposed to the general population, where the average age is around 65. About 10% of individuals with breast cancer and about 15% of individuals with ovarian cancer will be found to have a mutation in BRCA1 or BRCA2. But how common are these mutations in the general population? So in the general population, if you look at everybody out there, the average woman has about a 1 in 3 to 800 chance to have inherited a BRCA mutation when you're not taking family history into consideration. If you look at a population of breast cancer patients, 5 to 10% of breast cancer patients, again, not culling family history information, 5 to 10% of breast cancer patients will have a BRCA mutation. In breast cancer patients under the age of 40, this averages out to about 10%. And in ovarian cancer patients with a particular kind of ovarian cancer, the epithelial type of ovarian cancer, this is 10 to 15%. In the Ashkenazi population, this is 1 in 40. So because of the founder effect, which we talked about before, the genes, the mutations in the BRCA genes are much more common. In breast cancer patients who happen to be Jewish, about 10% of them will be found to have a BRCA mutation. In breast cancer patients who happen to be Jewish under the age of 40, this is 1 in 3. And in ovarian cancer patients who happen to be Jewish, this is about 30 to 40% of individuals. So clearly these genes are overrepresented in the Ashkenazi Jewish population. In fact, one of the things that has come out of recognizing this statistical information is that there are currently conversations about considering screening all Ashkenazi Jewish women, regardless of family history or other risk factors, for BRCA mutations. It's not something that is standard yet, but it is definitely something that has been a conversation and that people are seriously considering. So, a task for the class. Think about this is what the risks actually look like. When you look at the risk for breast cancer, you go from a 12% general population risk to approximately a 65% lifetime risk of breast cancer in the BRCA1 population and about a 45% lifetime risk for breast cancer in the BRCA2 population. When we look at ovarian cancer, that is a cancer that is not nearly as common as breast cancer. Less than 2% of women over their lifetime will get ovarian cancer. But in the BRCA population, that number is closer to 40%, and in the BRCA2 population, closer to 20%. So those numbers mean a couple of things. If you have a BRCA1 mutation, your risk for getting ovarian cancer is 40%, but your risk not to get ovarian cancer is about 60%. So when we talk about interventions, those are always numbers to keep in mind. Men, again, are not likely to get breast cancer in their lifetime, and even if you have a BRCA1 mutation, the likelihood of getting breast cancer is still in single digits. But in the BRCA2 population, men have now a measurable level of risk for male breast cancer. And this is the population that we want to find and offer screening to that most times haven't even been aware that they need screening. And this is the same when we look at prostate cancer. Although prostate cancer is the second most common cancer after lung cancer in men, and about 6% of men will experience prostate cancer, that risk is elevated slightly in the BRCA1 population, but more significantly in the BRCA2 population. When we look at other cancers, the two other cancers that have most commonly been seen are pancreatic cancer and melanoma. The pancreatic cancer, like ovarian cancer, is not a very common cancer, and we see single-digit elevations even across the BRCA populations. Melanoma, it's really hard to know what those numbers are because melanoma, like other skin cancers, can be heavily tied into environmental exposures. But it is recognized that there certainly are some families in which we see more individuals with melanoma than just statistically expected. This is a great graphic. I think the purple pink really jumps out to show that in the general population among women in the United States, about 7 out of 100 will get breast cancer by age of 70 and 93 will not. But in the population of women with BRCA1 and 2 mutations, when you average it out to 50%, that's every other woman. And that's why it's so important to be able to identify and find people who may benefit from more appropriate follow-up or from the appropriate. So this is a classic BRCA1 pedigree where you have a woman who comes in to talk about her family history because her mother's been diagnosed with breast cancer at 42, because her grandmother died of ovarian cancer at 49. She has an aunt with ovarian cancer at 53 and a cousin with breast cancer at 38. Not all family histories, of course, look like this, but this would be a guidepost. Everybody by now, I'm sure, knows who Angelina Jolie is. And I remember the summer of 2013 when Angelina Jolie wrote an op-ed in the New York Times called My Medical Choice. And My Medical Choice addressed the fact that she had always been aware that decisions which began. One of the other reasons for knowing why a person would have a BRCA mutation actually has to do with treatment. Pretty amazingly, has been the discovery of a group of medications called PARP inhibitors. So the BRCA genes kind of act as a prototype, and you may or may not have seen very recently some reports that there in fact have been discovered 72 new mutations. This is kind of more to come. So what are the other breast cancer genes, the other genes that significantly increase the risk for breast cancer? Well, they have name here. Here's some of them. They have names like PALB2, CDH1, STK, STIK11, TP53, PTEN, and CHEK2. So let's take a brief look at each one of them. All right. CDH1, the condition caused by mutations in this gene is called hereditary diffuse gastric cancer, or HDGC. And you can see that the reason it's called that is because there's a very specific pathology found in the gastric cancer associated with CDH1 mutations called diffuse pathology. Literally, the lining of an individual's stomach is taken over by flat cells that act like plastic and do not allow for normal digestion. The term for this is plastica lionitis. Most gastric cancers are going to be adenocarcinomas, like you see with breast cancer and colon cancer. So this is a very specific subpopulation of gastric cancers. Individuals, unfortunately, who do find that they have CDH1 mutations face significant increased risk for stomach cancer, up to 80% to age 80, more likely in women than in men, and face the decision about whether or not to have their stomachs removed, called a gastrectomy. There's also an increased risk of breast cancer, which is why this gene is on the list, but specific to not ductal invasive breast cancer, which is the most common kind of breast cancer that starts in the ducts, but lobular pathology, which starts in the lobules. Again, an increased risk, which is significant and can be as high as 50%. And recent studies suggest a possible relationship to colon cancer. Cowden syndrome, which is related to mutations in the PTEN gene, is also called the PTEN hamartoma syndrome. And you can see the risk here: increased risk for breast cancer, increased risk for thyroid cancer, non-medullary. Medullary thyroid cancer can be associated with a different group of genes. This condition is primarily associated with thyroid cancers that are called papillary or follicular. Endometrial or uterine cancer, increased risk, and colorectal cancer, increased risk. Cowden syndrome also has some interesting physical manifestations, such as skin papules, papillomatous papules, which you see in this picture, trichotilliomas, which are lesions that grow out of the bottom of a hair follicle, and acrokeratoses, which in the general population become more common as we get older. But we also see a significantly increased risk in benign thyroid disease or non-malignant thyroid disease, such as goiters, thyroid nodules, and hypothyroidism. Uterine fibroids, which are basically hamartomas, a particular kind of overgrowth in the uterus, and fibrocystic breast disease, which is relatively common in the female population, and a very unusual hamartomatous tumor of the brain called Hermit-Duclos disease. The STIC11 gene is associated with something called Peutz-Jeghers syndrome, and you can look down the list, I'm not going to go through it, and see that there are many different cancer types that are associated with these genes. The ones that stand out the most include ovarian cancer and breast cancer and colon cancer. So again, knowing that means that you can look at a family history, look at a pedigree, and say, if there's a pattern of breast, ovarian, and colon cancer, which is not generally felt to be associated with BRCA mutations, that there may in fact be a STIC11 mutation involved instead. Li-Fraumeni syndrome is one of those conditions that just is associated with almost all conditions across the board and all cancers across the board, and cancers that unfortunately affect younger people. The lifetime risk when you consider all cancer types in individuals with Li-Fraumeni syndrome can be up to 100% in women and up to 73% in men. And these are situations in which you might see a 19-year-old or a 22-year-old with breast cancer. There are kind of hallmark cancers, though, when you think of Li-Fraumeni syndrome, and they include some incredibly rare cancers, which include cancer of the adrenal cortex, of the choroid plexus, any sarcoma of soft tissue like a sarcoma and a tumor in the muscle, osteosarcoma, which would be a tumor in the bone, and brain tumors, including sarcomas in the brain. When you see this combination or any of these types of cancer, probably Li-Fraumeni or TP53 mutations come to the top of the list for consideration. Here's another thought process, discussion point, and homework. Pick one of these genes that is not a BRCA gene, do some research, and write a patient information sheet about it. We have plenty of information on the web, and there's plenty of information that the testing laboratories provide us regarding BRCA mutations, but not as much for these rarer conditions. So ultimately, people come in to find out whether or not they themselves may in fact harbor a genetic change in one of these genes, a mutation. And that's where genetic testing comes in. There are about 9 laboratories in the continental United States right now that offer genetic testing for hereditary cancer syndromes. Most of them request blood. Some of them accept a saliva sample or a buccal sample. If you're asking the lab to look at a lot of genes, you may not be able to use a saliva sample because of the DNA requirement. Most insurers do cover the cost of testing. I hate for insurance to be part of this conversation, but it is. And a lot of patients, that's one of the first things they want to know. There's also been this debate, which has been very active right now, in terms of whether or not a particular genetic test result could be considered a pre-existing condition from the point of view of health insurance companies. Right now, and this is November 2017, insurance discrimination in the face of a known genetic mutation, or even the fact that somebody's had genetic testing, is illegal. And things are protected by both the HIPAA law, which prevents individuals from accessing medical records that they should not have access to, and the GINA law, which stands for Genetic Information Non-Discrimination Act. Both of these laws protect individuals who have health insurance from being dropped by their insurance, by having their rates changed, or if they were to change insurance companies, for them being rejected by a new insurance company. Life and disability insurers are not federally regulated, so these laws only apply to health insurers. And with the active discussion in Congress right now, there may in fact be changes to this in the future, but I don't think it's something that any of us really know what's going to happen. Right now, these laws are in effect, and right now, people are protected. But genetic testing used to be, let's look at the BRCA genes. That was then, this is now. Now we have what I tend to call a Chinese menu of genetic test opportunities. If there is a known mutation in a family, for example, single site analysis or looking for the specific mutation known in a family member can be the best way to go. If it's a specific condition that you're concerned about, such as hereditary breast ovarian cancer syndrome, which is the name of the condition caused by mutations in BRCA1 or 2, then analysis of just those genes may be the best choice. However, today we have multiple laboratories offering multiple panels. And that's why being able to recognize different patterns of cancer in a family become very important. Do you want to look at 2 genes, 8 genes, 28 genes, 47 genes, or 80 genes? And yes, there are panels that look at 80 genes. Now, one of the downsides to offering genetic testing that sometimes does color a person's interest in the test is the presence of a variant of uncertain significance. And the way I like to explain this is that there's just not enough data behind that specific genetic change to clearly classify that as either harmful, i.e. a mutation, or benign. And until there's enough data, the laboratories in general do not want to report that one way or another because they know that individuals may be making surgical decisions based on their test results. Generally speaking, a variant of unknown significance is not actionable right now, which means that you don't want to use that information to affect medical management, mostly because we don't know how to interpret it, either positive or negative. Once a laboratory reclassifies a variant, then that can be acted upon. Fortunately, about 70 to 80% of the time, a variant of unknown significance is reclassified as benign. Unfortunately, the time frame on reclassification for most of these variants can be years, which leaves some people living with significant uncertainty, which is why it really needs to be part of the conversation. Say you see a patient named Mary. This is not the same Mary I started out talking about, but this is her personal and family history. Mary was diagnosed with breast cancer at the age of 52. She had 4 brothers, one of whom passed away of unknown causes, but we're going to assume it was not cancer related, at the age of 49. Mary's mother had breast cancer at 70 and melanoma at 79, and she had an aunt with breast cancer at age 70. Would you offer her genetic testing? Why or why not? And if yes, what type of test would you offer? Because of the risk of melanoma in some families, dermatological exam every 6 months to a year is also recommended. I generally say to my patients, make friends with a dermatologist. And for men, prostate exams start early. In the general population, maybe 50 or 60. In men with BRCA mutations, especially BRCA2, you might want to start earlier. And breast exams, which are something relatively unusual in the BRCA population. Unfortunately, there are currently no current protocols for early detection of pancreatic cancer, but there are research projects in place in Boston and other large cancer centers around the country to address what does the current best screening protocol for pancreatic cancer look like. Medications have been identified which significantly decrease the likelihood of getting breast cancer, even in women with BRCA mutations. For premenopausal women, that's specific to a medication called tamoxifen. For postmenopausal women, there's a series of medications, one of which is known as relaxifene. These were previously used to reduce the likelihood of getting breast cancer a second time in breast cancer survivors. But that trial was so successful that the trial was actually stopped early to release that to general population use. And it now can be used in BRCA carriers who personally have not experienced a diagnosis of cancer themselves. The use of these medications can reduce the risk of breast cancer by up to 49%, which is significant. And then there's surgery. It is a long, hopefully thoughtfully considered decision for any woman to remove her breasts. But for those women who consider that they have a significantly elevated risk likelihood to get breast cancer over their lifetime, it is a real point of conversation and it is a real intervention. I know quite a few women with BRCA mutations who have spent years doing imaging, maybe having biopsies along the way, who at some point decide finally to have a mastectomy. One such woman I work with in Pennsylvania who was found to have a BRCA mutation, who went for screening, who had several biopsies, which are not comfortable, and showed up in our office one day just to visit and say hi, so she said. Took her back to the exam room, and she told me that she had had bilateral breast surgery, that she had had her breast removed, and that she was getting tattooed, and did I want to see? Before I even had a chance to answer that question, she literally pulled up her shirt. So it is a real thing, and this woman was very proud to have taken this preventive action for herself. And I was proud of her, although I'm not sure I was ready to exactly share that experience with her. In terms of the risk for ovarian cancer, hysterectomy with removal of the tubes and ovaries, primarily removal of the tubes and ovaries. There's a small population of women, specifically, again, Ashkenazi Jewish women with BRCA mutations, who may be facing a significantly increased risk for an aggressive form of uterine cancer. But in the rest of the population of women with BRCA mutations, that's not something that is seen frequently, and so it's the fallopian tubes and the ovaries that usually the recommendation is for removal. And this can impact a person's decision about childbearing. A young woman who comes in to consider gene testing for a family history of breast and ovarian cancer, part of that conversation should be whether or not they have completed their childbearing, because this is going to impact that. There are several great support groups out there who have been developed by and for women with BRCA mutations. The oldest of these just had its 25th anniversary, called FORCE, standing for Facing Our Risk of Cancer Empowered. I would encourage you to look at the website. It includes both information about activities. They have a yearly conference and also have a peer-to-peer, which means that if you're a woman who has a BRCA mutation and wants to speak to someone who's had a similar experience, either at the same point in your journey or someone who's not a family member or close friend, they will hook you up online with somebody. Bright Pink was developed mostly for women under the age of 50 with um, the same cause, to bring information, support, and connection to women who have BRCA mutations. Now, while these groups grew up around the idea of BRCA mutations, they are very, very welcoming to people who have mutations in other genes that are associated with increased risk for breast cancer. Today, we also have an online database called PROMPT for Prospective Registry of Multiplex Testing. And any woman who has had genetic testing, woman or man, has been found to have a variant of unknown significance or a known mutation is invited to share their de-identified information onto this website. So no names, no addresses, no identifying information, just information about your family history and your specific genetic change. And that information, this was all came about through a process called Free the Data. So you might want to read about that. And researchers and clinicians can now go online and look at what information you may be able to find about that variant or that mutation. Recently, Prompt has also started creating some information specific to different gene mutations. I'm not telling you to cheat when you make up your information sheet to look on Prompt, but maybe you want to take a peek afterwards.